Hello everyone, I'm Dr. Tim Chismar, State EMS Medical Director at MIMS, and welcome to the 2020 Maryland EMS Protocol Update. I want to thank you for giving us a few moments of your time to get up to speed on the latest updates for EMS in the coming year. I'd like to start out by expressing our deepest gratitude for the expert care you have provided to Maryland's patients during the COVID-19 pandemic. In light of these challenging times, the Maryland Medical Protocols for EMS 2020 updates will go live on August the 1st this year. For the acute coronary syndrome protocol, we've placed an emphasis on early aspirin administration for patients with any signs or symptoms of ACS. These include chest pain, pressure or tightness, pain or discomfort in the arms, jaw, neck, back, or stomach, shortness of breath, or unexplained dizziness, nausea, or diaphoresis. Additionally, we are emphasizing that EMS clinicians should obtain a 12-lead EKG within 10 minutes of arrival on scene. For the Cardioversion protocol, we've simplified things a bit. For SVT, atrial flutter, or ventricular tachycardia, the initial shock will be at 100 joules, followed by subsequent shocks at 200 joules, then 300 joules, then 360 joules, or per manufacturer recommendations on the cardiac monitor. For atrial fibrillation, the initial shock will be at 200 joules, followed by subsequent shocks at 300 joules, and finally 360 joules. Of note, there's no change in dosing for pediatric patients. For epinephrine and out-of-hospital cardiac arrest, we will limit the dose to 1 milligram of 1 to 10,000 epinephrine every 4 minutes for a total of 4 doses. If an arrest recurs after a ROSC is obtained, EMS may administer an additional 2 doses of epinephrine. For pediatric patients, similarly, 0.01 milligrams per kilogram of 1 to 10,000 epinephrine every 4 minutes for a total of 4 doses will be given for the initial arrest. EMS clinicians may repeat 2 additional doses if an arrest recurs after ROSC is obtained. The epinephrine drip replaces dopamine this year as the primary EMS vasopressor. We are advising ALS clinicians to mix 1 milligram of epinephrine, either 1 to 1,000 or 1 to 10,000, in 100 milliliters of lactated ringers. Then, using a 60 drop set in a 20 gauge IV or larger, start the infusion at 1 ml per minute, which is equal to 60 drops per minute or 1 drop per second. We will advise ALS clinicians to titrate to a systolic blood pressure of 90 or a mean arterial pressure of 65. If the patient does not meet these blood pressure targets, the drip may be titrated to a maximum of 2 milliliters per minute, which is equal to 120 drops per minute or 2 drops per second. Medical consultation will be required for all pediatric patients receiving an epinephrine drip. For patients less than 50 kilograms, the following dosing chart will be provided. We will ask EMS clinicians to titrate the epinephrine drip to the following blood pressure goals. For patients 10 years and older, a systolic blood pressure of 90 will be used. And for patients less than 10 years of age, we will ask the clinician to titrate to a blood pressure of 2 times the patient's age in years plus 70. Throughout the summer months, EMS is frequently called to respond for patients experiencing exertional heat illness. If active cooling is available on scene with an event or team physician, EMS should allow cooling to continue prior to transporting until either the patient's body temperature is less than 102 degrees Fahrenheit or the patient's mental status has improved. In cases where there is disagreement about the need to transport versus continue active cooling, an EMS clinician may contact you for further advice. We've incorporated several stop-the-bleed principles into our bleeding management protocols this year. These include the application of direct pressure as soon as possible after arrival of EMS on scene, the application of tourniquets to extremity wounds, and finally, the placement of wound packing, particularly with hemostatic gauze if available, to central wounds which are not amenable to a tourniquet. In an effort to prevent hemodilution and coagulopathy, we're advising EMS clinicians to limit the amount of IV fluids given to patients with suspected hemorrhagic shock. We're advising EMS to deliver fluid boluses of no more than 250 mLs at a time with a subsequent blood pressure recheck. For adults, we're using a systolic blood pressure goal of 90 millimeters of mercury and a mean arterial pressure goal of 65. However, if there is a suspected head or spine injury, we are advising clinicians to titrate to a blood pressure slightly higher of 110 systolic. The blood pressure goals for pediatric patients are unchanged at 2 times the age in years plus 70. For termination of resuscitation for pediatric medical patients defined as patients less than 18 years of age, ALS must be on scene. The patient must have received at least 15 2-minute cycles of high-performance CPR, and at the 30-minute mark, there must be a systole and an end-tidal CO2 of less than 15, and the patient must have at least had 1 dose of epinephrine administered at that point in time. Additional factors that need to be considered with pediatric medical termination of resuscitation include that there is adequate social and emotional support and scene safety, and that the scene is amenable to leaving the patient on scene. For pediatric trauma patients defined as patients less than 15 years of age, ALS will be on scene in most cases. In order to terminate resuscitation on these patients, at least 5 2-minute cycles of high-performance CPR should have been delivered. On the cardiac monitor, there should be a systole and an end-tidal CO2 of less than 15 millimeters of mercury at the 10-minute mark. And finally, adequate support on scene should be available. In the rare case that ALS is genuinely unavailable, BLS may use the pediatric termination of resuscitation rule for trauma patients only. In these cases, the patient should have received at least 15 2-minute cycles of high-performance CPR, and during the 5 AED analyses immediately prior to the termination of resuscitation, there was a no shock advised, and adequate social support should be available on scene. This year, we've expanded the indications for ketamine. For CPR-induced awareness, which may occur during high-performance CPR, we are advising ALS clinicians that they may consider 1 milligram per kilogram of ketamine IV or IO, and for pediatric patients, they may obtain medical consultation to consider administering ketamine for CPR-induced awareness. For ventilatory bucking, we're advising ALS clinicians that they may administer 2 milligrams per kilogram of ketamine IV IO every 15 minutes for a maximum of 3 doses. Additionally, there are 2 new protocol changes that I'd like to highlight. The first is an evidence-based intervention for nausea and vomiting, in which an ALS or BLS clinician may use an isopropyl alcohol wipe and allow the patient to inhale the vapor from that alcohol wipe 3 times every 15 minutes as needed for nausea or vomiting. Finally, the consultation requirement for Benadryl or diphenhydramine has been removed. In closing, I would like to thank you for taking your time to complete this EMS Space Station update. I would like to thank you for your continued dedication to the MarylandEMS system and all of our patients.